My name is Emilee Benos, and I am a second-year MPH student at George Washington University. And like Hiba and Bridget, I was also in Morocco, but my study focused on Casablanca, and my study is called The Epidemiology of Pediatric Brain and Central Nervous System Tumors in Morocco. So a little background on pediatric brain tumors. 26% of all pediatric cancers worldwide are pediatric brain tumors, and they are the second most common pediatric cancer, and they are also the most common solid tumor in children below age 15. So the majority of research on pediatric brain tumors is conducted in high-income countries. There are very few research projects focused on low and middle-income countries, especially Morocco. One of the most recent, to my knowledge, was done by Dr. Solomon and my on-site mentor, Dr. Karkouri, back in 2010. So one of the main, my project had 3 different arms, and so the first arm that I focused on was an updated epidemiological profile of pediatric brain tumors in Morocco to get recent and updated information. And the second focus of my study was the treatment profile and treatment pathways of these patients with pediatric brain tumors. And the third arm was underestimation, which I will touch on later on in my presentation. So my study was a retrospective study of the epidemiological and treatment profile of pediatric brain tumors at Ibn Rushd Hospital in Casablanca, Morocco. So I reviewed charts of patients aged 0 to 19 diagnosed with a pediatric brain tumor during the years 2008 to 2018. And I looked at the pathological profile, diagnosis, treatment, and demographic information like age, sex, insurance status, address, and city where these patients are coming from. So I began my research with pathology. I gathered about 426 cases from pathology from that 10-year period, and I compiled all of these cases into one database, diagnosed at the hospital during that years. And then I moved on to pediatric oncology, and I began supplementing information, so adding more treatment information for these patients already collected, and getting more patients who were treated with chemotherapy at this hospital. So I got an additional 124 cases from pediatric oncology, and then I got access to the Casablanca population-based registry, which was about 243 cases after I eliminated duplicates, as well as the hospital-based registry with about 153 cases to supplement and add missing information. And I also looked in the radiotherapy departments and the neurosurgery departments to supplement information for my cases. So I merged cases from all of these sources and matched these cases and eliminated duplicates, which was an entire process within itself, because as both Hiba and Bridget mentioned, sometimes the names would be different, birth dates weren't really recorded. There's sometimes conflicting data between the different sources of information, so that was an entire process that I did. And so I included all histopathologically confirmed cases from 2008 to 2018 as my gold standard, and ended up with 545 cases. So my initial results are very preliminary, but it is in keeping with previous research, and that males are slightly more or the people with pediatric brain tumors, they're more males than females, with 54% being males and 46% being females. And I grouped these into age groups using the WHO standard age at diagnosis, and the most common age group was ages 5 to 9, which is in keeping with previous research, followed by ages 15 to 19 and ages 10 to 14. And for these ages, I plan to further analyze by sex and histopathological subtype. And so these are the top 10 histopathological subtypes that I got from my cases, with both medulloblastomas and pilocytic astrocytomas as the top 2, which is in keeping with previous research. But what I found was different from previous research is that now we're seeing that glioblastomas are the 3rd most common cases, which is very interesting because glioblastomas are a rare tumor in children. And I will touch on this later. I had a conversation with a pediatric neurosurgeon there who gave me maybe a hypothesis as to why this might occur. And these are the other top 10. And I plan on getting numbers for all histopathological subtypes that were presented in my cases, and doing a sex ratio for each histopathological subtype and the most common age range. So for the treatment arm of my project, I found that 25% of all my cases received chemotherapy. And I spoke to the head of pediatric oncology about this number, and she was very surprised. She expected about 50% of these cases to have received chemotherapy, but we found only a fourth of them did. And so I looked at that further, and medulloblastoma patients, the protocol is for all of them to receive chemotherapy. However, only about half of them are receiving chemotherapy. And I hypothesize that this is due to a gap between symptom onset and diagnosis and treatment, so that the late diagnoses might be playing a big role in this. So I was able to collect information on this gap, when symptom onset was and when these patients were brought to the hospital and when they began treatment, and it ranged anywhere from 2 days to 5 years. So in my future analyses, I plan on running some numbers and getting some solid estimations and numbers as to why this might be happening. Also, again, lots of missing data, lots of conflicting data. That was a big finding for my research study. And so for my future analysis, I will continue to look at insurance status. As Hiba and Bridget mentioned, most of these patients are under RAMED, which is like the Moroccan equivalent of Medicaid. I'm also going to look at referral patterns, so maybe do a spatial analysis as to what cities these patients are coming from. So we've had a lot of patients in Casablanca, but we also had a lot of patients coming from a place called Ouarzazate, which is on the other side of the country, and Agadir, which is on the bottom of the country, and Casablanca is like right up there in the middle. As well as the treatment profile of patients, so which patients are receiving radiotherapy, which are receiving chemotherapy, which are neurosurgery, which are all three, which are a combination of those two, and how many patients receive surgery and not any kind of treatment, so how many were lost to follow-up, as well as underestimation. So right now, the population-based registry only collects malignant cases, and I collected both malignant and benign cases. So there were 243 cases in all of Casablanca for the population-based registry. However, I found 426 in one department in one hospital alone. So that tells me that there's some significant underestimation going on about the disease burden. So the key things that I learned, not just about the Moroccan healthcare system in general, but the importance of accurate and complete data collection, as well as communication and collaboration between departments, which is very, very important in collecting research data and things like this. And I learned that epidemiological research is very multifaceted, and it requires a multidisciplinary collaboration to really get at the root causes of why these gaps might occur. So one really cool thing about my study was that it opened the doors to a lot of future directions, I think, for studies. So I think it could benefit from a multi-center study. So Casablanca acts as a magnet for all patients who are looking to be treated for pediatric brain tumors, so I can extrapolate my data and have it be representative of the country. But I also think that a multi-center study would be very beneficial because, again, as Hiba and Bridget mentioned, there is that disconnect between private hospitals and private clinics sharing information. So if patients or people were able to get information from those private clinics and incorporate that into a study, I think that would be very beneficial. Also, neuroblastomas. So I had a conversation with a pediatric neurosurgeon who mentioned a need for epidemiological studies on neuroblastomas specifically because there is a large lack of epidemiological data on neuroblastomas, and they're very poorly understood and very, very poor outcomes. And she mentioned that some epidemiological studies were desperately needed in the country. And outcomes and mortality. So when I originally planned this project, I planned to look at outcomes and mortality in addition to treatment, but plans change, as we all know. So that information wasn't available at all in Casablanca, in Morocco. So I had a conversation with an epidemiologist at the university, and she told me about this new death certificate that has just been implemented at the end of July. So it's in Casablanca starting about 3 weeks ago, and it's very comprehensive, and it's a hospital-wide death certificate. So now this is one step forward to cohesiveness between departments and ensuring that accurate mortality information is collected. And I think it would be very beneficial if a student, if not next year, then maybe the year after, went back and looked at these once these information was available. And the epidemiologist told me that it goes through the Ministry of Health, which could take about 1 to 2 years for this information to be collected. But she is in the process right now of hiring somebody to try to expedite this information in this process. So the strengths and limitations of my research site are very similar to Hiba and Bridget's. There's a big lack of communication and collaboration between departments. And by lack of, I mean almost none. So that was really difficult, but it was interesting to try to overcome that. And big shout out to Dr. Karkouri. As Dr. Solomon mentioned, we could not have done it without him. He acted as the liaison between the departments for us. So that was hugely helpful. And the incomplete data, sometimes they couldn't find patients, they weren't sure where to look, or if they could find a patient, the name would be on the folder, you'd open up the folder, there'd be nothing inside. So there wasn't really much you could do there. But a big strength of this research site was the enthusiasm of the staff and the mentors. It was such a great honor to work with all of these people at the hospital. They were so willing and eager to help and went above and beyond to make sure that we had everything we needed and we got the study done. So my future career goals and plans, I'm not entirely sure what I want to do yet, but I do know that I'm very interested in a multidisciplinary approach to human health, from the cellular all the way up to international governance. And I'm very interested in healthcare delivery in low-resource settings. I always envisioned research playing a big role in my career, but beyond that, I'm really interested in implementation science. So the application of this research data into actionable and efficient and effective solutions, as well as the clinical applications of global health and global health medicine. So with that, I want to say a big thank you to Dr. Solomon for being such a great mentor and being really helpful throughout this whole process, and the CEASE board for giving me this great opportunity. Everybody at the hospital, Dr. Karkouri for being such a wonderful mentor, whether it was contacting a department or booking a riad for us in Marrakesh. He was so helpful throughout the whole process. Ibrahim, Wafa, Rehab, everyone at the hospital, they were incredible to work with, and I couldn't have asked for anybody better. And Hiba and Bridget for being my friend, not that you had much of a choice. And it's Hiba for being my unofficial physician, Bridget for being my unofficial French mentor, tutor. It was great. It was all a great experience. And thank you all for listening to me.